They changed all the rules last year, so there's extra stuff crammed in there now. Yeah, so, sorry, I emailed them on Friday. Apparently there's something wrong with how you guys get the lectures. So if you guys need copies or whatever, then I will email them directly to you so you can have them. Because this is not going to be fun trying to do this if you guys don't have anything to look at. But anyway, does anybody here in your lifetime, have you guys ever been like cardiology clinic or have you shadowed or anything? One? So did you get to see any of the rhythms or get to learn about that? Okay, so this is the most common rhythm, is atrial fibrillation. It happens very frequently. Mostly we see it in the elderly, but we can actually see it in young people because it comes from all different reasons. Have you, just so I know what you guys have done so far, since this is new for me, have you guys already done like physical examination and all of that as far as training or teaching or learning?
All they've had so far were valvular disorders and a little bit of physiology.
Okay, so this will be really confusing then. So if you're taking somebody's pulse, when they have atrial fibrillation, so you know your normal pulse is just, you know, boom, 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 very regular. This one is all over the place. It might be 200 beats a minute and just all over the place. It is not regular at all. And it can go anywhere from being a slow rhythm to a very fast rhythm. Usually it's a very fast and irregular rhythm. A lot of patients have no symptoms. The most common symptom is just fatigue. They'll come in just saying that they're tired. If you do an EKG, which generally if you're having somebody that you can hear has an irregular pulse, you're going to do that first. Their EKG is very irregular, and I'll have some pictures of that in just a second. So have you guys had the cardiac physiology, so you know how the heart works and pumps and all that yet?
Yes.
Okay, so if you have atrial fibrillation, the top little chambers, instead of doing this to get blood down into the bottom of the heart, are doing this. So blood really isn't flowing very well, and there's a big risk of forming clots in the atrium, which then can give you, go to other parts of the body, and you can have strokes, PEs, and things like that. It is more common in the elderly, but young people can have this as well. These are some of the causes. A lot of times there's no cause. You don't know. It can be from anything. I see it quite frequently after somebody's had some kind of just upper respiratory illness, and they'll come in and have this. I don't see it very often in the urgent care, although since I've been working on the lecture, I've had 3 people in the last 2 months that came in with acute onset of atrial fibrillation. So, helped me out with that. Valvular disease, if you guys just had lectures on that, can be a cause of atrial fibrillation. If those aren't working right, it can send that into an abnormal rhythm. These are some of the reasons where there's a normal heart and nothing else going on. There's medicine stimulants, so all you people drinking like, Red Bull, stuff like that, so you can go into AFib from meds. Alcohol excess or withdrawal can do it. Lots of caffeine. If you have pulmonary disease, so people with COPD can go into AFib just from their COPD. Most common sign is fatigue. They just come in saying they're tired. Fatigue is one of the worst things to have to work up in the clinic because it can come from a multitude of things, but this is one of them. Palpitations, where they feel like their heart's not beating correctly, where they feel like there's abnormal beats. You can definitely hear it when you listen to their hearts or manually feel their pulse. It is so irregular, nothing sounds right. You'll feel pulses and not be able to hear the beats when you're listening to them, and vice versa. This is just, and this will help you in the long run when you're studying, but I am not going to go over this chart. Now, I'm going to see if I can get this to work. to turn it down, sorry.
I kinda like it.
Well, I guess we probably need a little soft. Little moon music. It should go into the video, and it just kind of shows you how, what happens in the heart, the atrial fibrillation.
That works continuously, much like a pump. Each beat of your heart is set in motion by an electrical signal from the sinoatrial node, also known as the SA node. The SA node is in the right atrium, one of the two upper chambers of your heart. The electrical signal spreads across the cells of your heart's right and left atria. This signal causes the atria to contract and pump blood through the open valves from the atria into both ventricles. The signal arrives at the atrial ventricular node, also known as the AV node, near the ventricle. Here it slows for an instant to allow your heart's right and left ventricles to fill with blood. During atrial fibrillation, the atria contract very rapidly and irregularly. This happens when the electrical signal begins in a different part of the atrium than the SA node. Abnormal electrical signals tend to begin in the left pulmonary veins, rather than the SA node. Atrial fibrillation also can happen if the signal is conducted abnormally. The abnormal electrical signal causes the walls of the atria to quiver rapidly, or fibrillate, instead of contracting normally. As a result, the atria don't work efficiently and don't pump all their blood into the ventricles. If all the blood does not flow into the ventricles, the blood that remains pools in the atria. If blood pools in the atria, clots can form. This increases the risk of stroke because part of a clot can break off and travel to the brain. During atrial fibrillation, the ventricles continue to contract from the heart's electrical activity. However, the abnormal electrical signal traveling from the atria through the AV node make the ventricles beat faster than normal. As a result, the ventricles don't pump blood efficiently. This can lead to heart failure, a condition in which the heart cannot pump enough blood to meet the body's needs. In patients with atrial fibrillation, there are two main therapeutic strategies. Whichever strategy is
So that's basically just what is going on in the heart with that. This is what it looks like on EKG. So I don't know how well you guys can see that, so maybe you're not getting it on your laptops, but I brought my toy here so we can, I have a rhythm generator so we can play with that later, and I'll show you what it looks like. These are two different slides. The top one is normal, what a normal EKG strip should look like. The bottom one is AFib. So you can see that none of the beats are coming regularly as far as the QRS, and then you've got all those little, that's the fibrillation you can see along the bottom part of the EKG. It just looks quivery and there's not a noticeable key wave. There's a couple other ones. So the bottom one is typically what it looks like. It's usually very fast, and you can see how close together the beats are. It usually runs anywhere from 160 to 200 beats per minute. So you can imagine they're not perfusing very well, so people often complain of shortness of breath as well. They're not perfusing very well. So there's two, when you treat patients that have atrial fibrillation, if they are unstable, like if they're in shock, if they have a lot of hypotension, if they're building up fluids in their lungs, which is pulmonary edema, if it's making them have a heart attack because they're not perfusing the heart, then they are considered unstable and you immediately go into shocking them back into rhythm. The hemodynamically stable patients go into categories of paroxysmal, persistent, or permanent. That just goes along with diagnosing which kind of AFib it is. Most people are paroxysmal, which means they just kind of go in and out of it periodically. Persistent, that happens over time. It becomes more frequent in episode until it becomes a persistent. Permanent is where basically medicines are not working anymore. It will not go back into normal rhythm and stay there. When it reaches that stage, then patients work with their providers and usually decide we're not going to do anything else about it because nothing's worked. Secondary AFib, those are primary AFib. Secondary AFib is just all of the other things that some of those can be reversed. So if they're diabetic and they're not well controlled, well, that may be why they're having AFib. So if you fix that, then their AFib may go away. Kind of like hyperthyroidism. If you fix that, it may go back into normal rhythm and stay there. So, unstable patient treatment. Urgent cardioversion. If they are unstable and not perfusing, they will start forming clots all over the place. So you have to anticoagulate them and shock them. And this happens generally in the emergency room, not in your office. Like, I'm not going to be shocking anyone in the urgent care. There is a medication that they use. If the original cardioversion, if you shock them once and it doesn't work, you can give them Butylide and then re-shock. A lot of times that will help them stay in rhythm. There are some risks with the medicines, however. Butylide, and there's some other ones later on that can actually, they can go into a worse rhythm. So you have to be careful in giving the medication for it. The hemodynamically stable patient, so if they're just a little fatigued and not having any signs of shock or hypotension or pulmonary edema, you just start in the office. Generally, you can start some therapy while they're there, but you need to do a workup, like just a really good history and physical, always an EKG, electrocardiogram or an echocardiogram, both. Some blood tests, which that you want to make sure that they don't have hyperthyroidism or any other, if they are now diabetic, you need to treat those, so you need to do some blood work for that. The H&P, the symptoms. What symptoms are they having? Do they know they're in AFib, or did you just find it because you were listening to their heart? Some of them have no idea. You'll listen to them and they'll be completely irregular, and you'll ask them if they're having palpitations, if they're tired. Nope, feel fine. They may have no symptoms at all whatsoever. The clinical typing, again, there's the first episode. That's when the first time either you find it or they come in and say, hey, this just started and I don't feel right. Then it goes into the paroxysmal persistent permanent. Paroxysmal is usually if it's been less than 7 days. If it's over 7 days, it's persistent. And then permanent is, again, what you decide. When did it happen, or when did it start? Very important. If it's less than 48 hours, that makes a difference in the long run. You can immediately have them cardioverted or medically cardioverted drugs. Had they ever had it before? If they've ever had a response to previous treatments? Obviously, people don't always continue taking their medicine. So if they've had it before and were on treatment that was working and they thought, okay, this is better and I'm going to quit taking my medicine, and lo and behold, it came back. Believe it or not, patients do that all the time. And then the presence of cardiac disease or any other reversible conditions, once again, like thyroid disease, diabetes, if they have COPD that's not treated, anything that can contribute to them having symptoms or going into to address that more correctly. EKG, standard method to use for identification. Yes, you can hear it and you can feel it, but you need basically the paper for proof. So sometimes you have to either put them on telemetry or sometimes a Holter monitor. If they're going in and out of AFib, which happens a lot, you may not be able to find it on a simple EKG. It may not be happening at the time that they're in the clinic. So Holter monitors are very good at finding that. You guys know what Holter monitors are? No, okay. Basically, that is a long-term monitor. It can be on anywhere from 24 hours to a month. It's a little cardiac monitor. They put little stick-ins on your chest, and it's a little, some of them are as small as it looks like a little battery pack that you carry around with you while you're hooked up. And most of them have little buttons, so if you feel like something's not right, you hit the button and it records it on that device. And then you take it back into the doctor, or the usually respiratory therapy does it, and they can read and see what kind of rhythms you were having, and see if you were going in AFib. Okay, we're gonna check for right ventricular hypertrophy. That has to do with basically your lung function. If that is hypertrophy, then you may be having lung disease that needs to be addressed. You need to check for something, we'll get into bundled branch blocks later, but, and check and make sure that they have not had an MI, which generally you can see from the EKG. And you can do measurements on the, like, QRS and all of that, just to see how fast the rate is. This is what the echocardiogram is for, to check for valvular disease. So if you've already had a lecture on that, that's the way to do it. And there's two different ways. You can do transthoracic or TEE, which is much better at finding clots, especially in the left atrium. It's a little harder to see in there. So that one's a little bit better for that, especially if you're going to acutely shock somebody. You want to know if there's a big clot in their left atrium. So generally, they will do one of those if they are in the ER and getting ready to zap somebody. They will check that. Lab tests, again, which generally you're going to do general lab, so you'll check for anemia with the CBC, you'll check their thyroid, renal function, hepatic function. Some of the renal function testing is due to the medications that you use. The newer medications, like the direct thrombin inhibitors and things, affect the kidneys, so you have to have baseline kidney, and then dabigatran also affects hepatic function. These are just some other things. Most of these are like electrophysiology, and the walk test or the exercise tests are basically for after they're on medication. You want to make sure that they're not having rate controlled breakthrough, so you may re-examine this later when they come back from checks. If their rate's going out of rhythm with simple exercise, then your meds are probably not working very well. Okay, so a little deeper into this. Obviously, this is pretty self-explanatory. It's the first time that it happened. Paroxysmal, this is the 7 days or less generally is the paroxysmal, and it usually goes in and out. Like, they may go into AFib for a few minutes and then it go back out. They may be in it for a day and then it go back to normal. But it's usually a recurrence. And then persistent is if it's longer than 7 days, and then continuous persistence, they renamed for over 12 months. Most of these people, once they have it forever. Chronic AFib, or permanent AFib, once again, this is what you determine with the patient. If it, as far as treatment, if it's permanent and doesn't go back out with medications, then they just have it and you have to deal with the clotting. I put this in here just because all of the treatments say for, like the medications will say for non-valvular AFib, there's different rules. If it's valvular, you're generally just going to use warfarin. You won't use the other ones. They're not indicated for treatment with heart disease, or valvular disease. So this is the big one. What are you treating? One, you want to prevent the clots from forming in the atrium. Rate control, so if they're in the 200 range of how fast their heart's beating, it doesn't work real well at that rate, so you want to get that under control. Or correcting rhythm. Of all of the stuff that I looked at this, because they changed some of the guidelines last year, there's nothing that says to do rate control versus rhythm control. It's They just have discovered more of the cardiologists do rhythm control, most family practice, and other people do rate control. You can do either one, and sometimes both. This was a very helpful little slide. I wish you guys could see it. It's helpful in the long run because it just helps with, I actually got this, and I put a little link at the end of the slides. It's from the American Heart Association. This is a really good website for patients and even for yourselves. They have really good little charts like this for patients so that they can understand the process a little more. Most patients have no idea what you're talking about if you tell them they're in atrial fibrillation. So I spend a lot of time drawing pictures on our bed paper explaining that, but they have links to little like pictures, there's explanations. This is the pathway for treatment. And it has links in there for other disease processes as well that have to do with treating AFib. So whenever you guys get the slides, this one is very helpful for studying. So this is some of the mess that I had to look at for all of the information that they changed last year in the guidelines. There's a link to the actual paper that's like 30 pages long of about 50 to 60 clinicians that got together with all of these huge studies on atrial fibrillation and then made these guidelines. This is a chart basically for treatment effect. It's what guides the treatment. And there's levels of like what is appropriate and what's not appropriate depending on the patient's status. It's a little bit confusing. I'm not sure that you have to know this because it doesn't do anything in the end other than classify the treatments. But I stuck it in there so you can see where the information comes from. Okay, so preventing clots, this is a big one. You definitely do not want them having a clot and it going out to other parts of the body and killing them. So this is a little measurement for what their risk is for clotting, and it guides treatment. There are others. This is the most common one used. It's called the CHADS-VASc score. It used to just be called the CHADS-2 score, and they added some things in it last year. And once again, you can see for non-valvular AFib. So this does not count if they have valve disease or like artificial valves. So you want to know, do they have congestive heart failure, hypertension, age over 75, and this is very odd that they have age in there twice. If you see it again at the bottom, 65 to 74, adds another point. There are, I don't know, probably 10 different free things you can download apps to your phone to calculate the scores for you for this. It's very simple. Basically, age up at the top, so you get 2 points if you're 75 or above. Hypertension, you get 1 point. Stroke, you get another 2 points. Generally, anything over 3 in scoring, you're going to anticoagulate. 2 and below. 0 is pretty questionable on if you're going to coagulate. 1, if the 1 is only for either being a female or age, you can sometimes not anticoagulate. Depends on if they have any other, so if it's a generally healthy female of age 72, you may not have to anticoagulate her. If she has no other risk factors, there's no other like diabetes or anything else underlying. And I do have links for the guidelines for all of that in here too. So now the congestive heart failure, they don't even have to have the diagnosis of congestive heart failure, they just have to have the symptoms. So if they have symptoms of that and haven't been formally diagnosed, you can still consider them or giving them a point for that. Diabetes, once again, if you're in the midst of, you know, they came in with AFib and now you're having to test them for diabetes because they never go to the doctor. If it's possible, if you know you check their blood sugar in the clinic and it's 200, it's very likely they're diabetic. So I would throw in a point for that even the first time. Stroke, have they ever had? a thromboembolism anywhere, like have they had a DVT in the past, have they had a TIA, or an actual stroke. And then valvular disease, really, do they have any kind of heart disease? Coronary artery disease, peripheral artery disease. They threw in the age again for 65 to 74, and then the sex category, female. Not a yes or no question. Believe me, the patients will say, yes, we are having sex. No, it's not what they'll tell you the most bizarre things. Okay, so this is the risk base. The CHAD score is basically how you determine what the risk is for anticoagulation. So if they have 0 to 1, you may not have to anticoagulate them. And every time you see the patient in the clinic, you want to reevaluate the need for the anticoagulation. Because so if they were female 72 and diabetic, well, now if, things have changed, their diabetes has gone away, or they had like thyroid disease, and now that's under control, they may not have to be coagulated anymore. So this just goes over the scoring again. Generally, if it's 3 and up, you're going to coagulate or anticoagulate. And most people with 2 and above, once again, if it's because they're female and their age is between 65 and 74, you may not. That's where the 2 and under goes. So, aspirin. Now, just because you're not going to put the 72-year-old, female on one of the big clot medicines, you might give her some aspirin to take every day anyway. So you can anticoagulate that way. Aspirin, I don't know if you guys have had any laboratory medicine. You cannot check really for aspirin levels or anything like that like you can with Coumadin, but it affects the platelets. That's why it makes our blood thin. So you can check that with a simple CBC. Warfarin, most commonly used medicine, my least favorite drug of all time. It interacts with everything known to man. There's like a handful of drugs that it doesn't interact with. And they have to be monitored, which is somewhat of a pain, once a week until they are stable for a month, and then they get checked monthly indefinitely. There are clinics just to check it's checked with something called a PT and an INR. Now the other anticoagulants, the newer ones, which are the direct thrombin inhibitors and the factor X inhibitors, those ones don't require monitoring other than periodically checking their renal function and sometimes hepatic function with dabigatran. But those are the options for medicines. Cost is a factor there too. Warfarin, cheap, old. Newer ones, expensive. Most insurance don't pay for it. So aspirin, you can use it for the people that are very low score. There is some increased bleeding risk, like they'll bruise real easy when they're on this, but there's really no monitoring. Unless they have some kind of platelet disorder, you're not going to check that except at their regular lab checks. Warfarin, lots of increased bleeding risk, and it is very hard to control. It interacts with foods as well. So if you're eating a lot of things that contain vitamin K, which is actually the reversal agent for warfarin, so if you eat a lot of green leafy stuff, you can mess up your warfarin level. So that's why the monitoring is so frequent. Dabigatran, really, don't really have to monitor any of the other ones, other than renal function, which you're going to check in a general lab periodically. Now, warfarin, you can use that for valvular and non-valvular. So most of the other ones are non-valvular treatments only. They do not have the indication for that treatment as of yet. This, once again, you got to determine the INR. That's the little number And you have to keep them in a very narrow range of normal on that medicine. So it's a little bit of a pain, but it is the most commonly used. And they usually are anticoagulated in the hospital with like heparin or low molecular weights, like the linoxaparine. So. And then you just bridge them over into warfarin. So these ones are for non-valvular. Same thing, you're just going to check their CHAD score, you start them on their loading dose, and then they go. Now, this is a big messy slide. These ones, there is a ton of information on what to do very specifically. Have they had the process going on more than 48 hours or less than 48 hours? If it's less than 48 hours, you can cardiovert them and then start them on anticoagulation. If it's been going on more than 48 hours, you're going to have to anticoagulate and then zap them, basically. Or you can try medications to get them to convert instead of cardioverting them. Do you guys know what I'm talking about when I say cardiovert them? Okay, zap it, you'll hook them up and zap them. And this is very similar. A flutter is in here too. We'll go over that in a little bit. It's much easier than this one. It's basically the same treatment, and it looks very similar. There's just, instead of fibrillating, it's bigger. It's little, and it's actually harder to treat. Most people won't go back into it normal rhythm. Okay, there's some special cases with the anticoagulation and medicines you can and cannot use. So, people with renal disease, you're just basically going to have to, you still start with warfarin, you just have to start with a lower dose. Most of the direct thrombin inhibitors or the factor X inhibitors, you don't want to use in patients that have renal disease unless for some reason they can't take the Coumadin. And then once again, none of the thrombin inhibitors with mechanical heart valves. Okay, so that was all the anticoagulation. So now on to rate control. These are the goals for the rate control. Basically, you just want to get it where they're perfusing and comfortable. So just remember these are goals and generally not what actually happens. As long as they're not getting dizzy and they have blood going to all their tissues, they're good. Beta blockers are probably the most commonly ones used for rate control. I know this is very tiny, you guys probably can't see it up there. There's just a list of meds up there that you can use. Calcium channel blockers are another one. There's some problems with those if they have like congestive heart failure and things. You can't use them as readily. Digoxin is another one. That one is a really old medicine. It has lots of side effects, medication interactions. It has to be monitored, and it can become toxic. It can build up in the system and cause toxicity. So it's not used as often anymore. It's generally one used if nothing else is working. So most people start with beta blockers. Amiodarone is another one. That one, again, has some risks. That is one of the ones that can send them into a fatal rhythm. So they can go into like ventricular tachycardia and even defib, which is generally not good. Other treatments, you can have an ablation if they can find the spot in the heart that is actually causing the AFib, and it's just that is the problem. They can do an ablation where they go in there with basically a little electrocautery and zap part of the heart muscle until it no longer functions and isn't causing the atrial fibrillation to occur. And once again, the digoxin only if the others fail. That's not one you're just going to start somebody on. Okay, acute setting, so these are like if they're basically, they end up in the ER, they'll give them IV medications. That pre-excitation, that has to do with what something looks like on the EKG. It's basically where the P wave is running into the Q wave. They're so close together. And they generally won't use the calcium channel blockers if that's occurring. Probably the most commonly one used is amiodarone in that setting. That last drug, that was one of the ones that they changed in the guidelines. And I'm not sure why they put it in there, because in most of the slides it says, well, you can use this, but yeah, I probably wouldn't. So I'm not sure why they put it in there.
What does it mean by pre-excitation?
That's basically where, so if you have your P wave, there's your QRS, you know, forgive my drawing ability. So that's pretty normal, P, QRS wave. So pre-excitation is where the P wave kind of runs into the QRS. And you're getting this, like where it doesn't come back down all the way. It's more likely to go into an abnormal rhythm if that's present, other than the abnormal rhythm it's already in. Those are the ones that can send them into ventricular tachycardia. So this is just, I found this helpful because it's just instead of all the big jumbly mess, I really hope you guys look up this 40-page thing that I had to look at to get these, because this is way easier than what they had written on that paper. So it just gives you a guideline on if they have these things, which medicines are the best ones to use. So it helps when you guys are studying. Rhythm control. This one is probably, these meds in this group are the ones that are a little more likely to make them go into abnormal rhythms, which is probably why most primary cares and stuff use the rate control meds instead of rhythm control. More of the cardiologists use these meds. So rhythm control, basically this is where the cardioversion comes in. Must prevent the clots first. Don't forget that. You don't want to zap them into a normal rhythm. Their atria now start pumping blood normally, and there's a big clot in there that just goes down into their ventricles and out into the body. The Maze procedure, they go into the heart and they cut slits in it and let it heal where it causes scarring to hopefully deter whatever part of the heart was making the rhythm abnormal to begin with. So they do that a lot in the left atria if it stemmed from the left pulmonary arteries. And then pacemaker. That one, if they can't get them into any kind of rhythm and their rate or their rhythm is so abnormal that they're not perfusing, they can put a pacemaker in. You still have to prevent the clots with that. And then unfortunately, I'll tell you, the pacemakers don't always help with the rates that are real high. So a lot of them end up with pacemaker defibrillators. All right, cardioversion. This is the zapping process. So if they're hemodynamically unstable, basically they get zapped pretty immediately. If they're stable, they'll anticoagulate them, give them some other meds to try to bring them back in, and if it doesn't work, then cardiovert. Always done in the hospital. Unless you're in the back of the ambulance with one of these. Okay, so this are medication cardioversion. So these are meds that they can use to convert the rhythm back into normal. I know Dr. Latassi, I think, is doing a lecture on all of the meds, so she'll go over more of those in detail, but there's a list of those. Once again, Abutolide, that's one of the ones you can use during cardioversion. Amiodarone, that's also one you can leave them on orally. And I don't know if I still remember why they have that one in there. So the Defetilide, that one, we'll go over torsades in a little while, but you definitely don't want to go into that rhythm either, so that probably wouldn't be my first choice of medicine, but it is an option. So these are maintenance meds. After they've been cardioverted and they're back in normal rhythm, you gotta give them something to keep them there. So if you look at Sotalol, that one's actually a beta blocker, which is also used for rate control, so it can help with growth. So it's one of the more common ones used. Amiodarone is used a lot, even though it says only to use it when the other ones fail. See lots of patients on that medication. This is one of those big nasty slides again that came out of that wonderful paper. This is just more, basically it's in list form of what you do to prevent clotting, and then the little green and yellow things over there at the side, that was from that original slide that had where they determine what's a good treatment and what's not. So it gives categories on how good the treatments are. I don't think you have to know that in that much detail. Not even sure the people that wrote the paper know that. This one's a little bit easier to look at. So structural heart disease or no structural heart disease and the medications and treatments to use for that. This is much easier to look at. Okay, so when that first line there should not be continued when the AFib becomes permanent. Once again, the permanent part of that is when the patient and you determine that it's permanent and nothing's working. So if nothing's working, why leave them on all the medicine? You still anticoagulate them, but you don't try getting them out of rhythm or back into normal rhythm because it just doesn't work. And there's so many side effects and then risk of going into a worse rhythm. This is the catheter ablation again, where they go in and zap the little parts of the heart that they can find. They can do, that's what the electrophysiology studies do. They determine which part of the heart is actually what's causing, or the source of where the rhythm is coming from, and that's the part they'll go in there and burn it. This is also done for both Parkinson and Wright disorder. And once again, have to be coagulated. And then this is the maze procedure with the small cuts. I don't think that's actually done very often. I think it's done more overseas than it is here. And then pacemaker, once again, if nothing else is working and the rhythm is so abnormal or the rate's so out of control, it's worth pacing them just so that they're not throwing clots. Or where, you know, they're dizzy all the time and can't walk or can't stand up or can't function properly. But it does fail because sometimes just because of the, it doesn't control the higher rates very well. All right, that's the end of the terrible atrial fibrillation. That one was probably the worst one, so I started with that. The others would be easy. Atrial flutter, this one, you guys need a bathroom break or anything?
Yeah.
Yeah? Okay, let's take a break. The other ones will go fast.